So we are talking about adult spinal deformity, and we know that the prevalence of adult spinal deformities is about 60%, and it is increasing due to the epidemiological trend. We know also that pain and disability typically characterize adult spinal deformities. Moreover, we know that an anterior sagittal balance and pelvic retroversion increase disability. This is because the pelvis plays a fundamental role in the chain of correlations between spine, lower limbs, and sagittal shape. For what concerns Parkinson's disease, the knowledge about scoliosis and its correlation with sagittal balance is sparse. We know from a paper in which they evaluated radiographically scoliosis that the incidence was about 33%. Parkinson is correlated also with postural deformities, not only scoliosis, but also camptocormia, antecollis, Pisa syndrome. So the aim of the study was to describe the prevalence of scoliosis in Parkinson's disease patients and to define the existing correlation with sagittal balance in relation to the pelvic morphology. From a general database, 48 patients were included in the study, and 36 were males. For each patient, a clinical and radiological assessment was done, and we considered scoliosis when the cup angle was over 10 degrees. In the group with scoliosis, there was the 47.9% of the patients of the cohort, and the average value of scoliosis was then 22.3 degree curve. 84% of these patients has a thoracolumbar curve. For what concerns analysis of clinical differences, there were no clinically significant differences except for the ATR, as expected. The analysis of radiographical differences didn't find any statistically significant differences, but we found some differences clinically for what concerns lumbar lordosis. And so we found that lumbar lordosis was slightly lower, spinocerebral angle was smaller, and pelvic incidence was greater due to larger pelvic tilt. If we apply to this sample of patients with scoliosis the new classification made recently by Schwab for adult spinal deformity, we found that there was a moderate clinical impact on disability and pain for the group with scoliosis, while for the group without scoliosis we have 0 point for each modifier for the sagittal balance. We have to remember that in the sample of patients with scoliosis, camptocormia was more frequent, so we can suppose that postural control faults may favor the development of scoliosis. This study has some limits. First of all, the lack of a control population to compare results and a limited sample size. But it is a study which considered the X-ray evaluation for defining scoliosis, and most of the spinal and spinopelvic measures were analyzed. So some open question. We know that there are various factors which contribute to scoliosis, such as genetic, hormonal, biomechanical, and neuromuscular factors, and also that age-related degeneration and postural defects may fuel the progression of scoliosis. We don't know if conservative treatment can change some of these factors. So in conclusion, we found a higher prevalence of scoliosis in Parkinson's disease patients than previously described, and the predominance of thoracolumbar curve type. We found also larger pelvic incidence and pelvic tilt, and slightly lower spinocerebral angle. That means that these patients have a sign of compensation of sagittal and spinopelvic imbalance. some perspective. We need further study with larger samples to better understand the relation between sagittal shape of the spine and pelvis and scoliosis in Parkinson's disease patients. And further studies will highlight also the effects of conservative treatment. Thank you very much.